Welcome to the Pura Vida podcast. Today with Gian Lim, a wonderful friend and patient, and we will discuss the importance of checkups, also of course in correlation with hormonal health. Enjoy the show.
Welcome to the Pura Vida podcast. My name is Dr. Gabriel Salgo, and I'm your host.
Welcome with Mystery Man, Mr. Gian Lim, who is not only a very good friend, but also somebody who is used to dissect, analyze, and then put everything together in a very, very structured manner. And this is actually what we do in medicine. The same. I mean, you are a lawyer by profession and a very successful businessman. And I think this is the reason why lawyers become very successful business people, because you analyze first, and then you can put the things inside what is necessary and leave things outside what are making businesses maybe not as successful. And as I said, it's happening in a very similar way in medicine. You neglected your health in a sense of checkups for a long time.
Thank you for having me on, and good morning. That bit about lawyering, it was probably because I wasn't making a lot of money being a lawyer, so I decided to do business instead. But yes, it does help being a lawyer. I wouldn't say the health was neglected. I just didn't want to find out what was I didn't want to know of any issues or whatever. And I think that's quite common, until my wife forced me to.
Unfortunately, yes, that's very true. People are like, I don't want to know, which is for me literally very similar to getting into a car, driving onto the highway and saying, now I close my eyes. I don't want to know what's going on around me.
Well, anyway, I've happily undergone a test as prescribed by you. So from that point on, I think you piqued my interest to go deeper and deeper and find out more now.
To the stage where your wife is complaining now to me that she has to listen now to all the podcasts with you.
That is true. That is true.
And again, I find it very, very attractive and appealing because it helps people. So I'm a big fan of podcasts myself. That's why we are doing it. So I think education to people, why you need to do it, what is found out in this health checkups, what is a sensible checkup, is something that people should be aware of and even ask for it.
Well, actually, that was something which my wife was telling me about. That your protocols for a checkup is very different from what a normal Malaysian GP clinical doctor would prescribe. So and I remember going through this with you when we had the questionnaire. And the amount of actually not the amount, but the different tests which we would have to go through, not one lab would be able to fulfill it. Quite a few different labs. So it was not a standard checkup, which was what I liked, because I think that is obsolete. That's been around too long, and I don't think that's very useful. That was also another reason why I didn't bother with checkups, because they don't pick up on things which I felt were relevant. So yeah, anyway, that's where we were. So I just found where the checkup which you listed out was a lot more useful for making sure you live better,
I think that's very correct. I understand that most hospitals or GPs do not have the time nor the capabilities to do these extensive checkups, because you need very cooperative patients. So, as you said, the questionnaire that I'm sending out is alone 11 pages. So, and just as you, most people are like, why is he asking these questions, which might not be sensible in the very first round?
Well, actually, when my wife said, you've got to fill in this questionnaire, I said, no, but just tell Gabriel, I will tell him tomorrow when I see him. And that was the day before. And it was like, no, you have to do it now, because then you actually have some quiet moments to reflect about it and speak in detail or write in detail, and so that we get a proper analysis of the medical report later on, which is the right way, which is really the right way.
Yeah, I think without a questionnaire, honestly, I don't want to see people. So a lot of people are sending me blood tests, etc. Without the questionnaire, I'm not able to really bring the blood test into the context of the complete problem, for example.
So that's to do with medical history, I assume, and also the lifestyle.
Correct. Lifestyle, little things like when did you start to lose your hair, skin problems, nail problems. These can reflect on hormonal problems, for example, on stress. So that's why also, what are you working? How many hours do you work? How many hours do you sleep? And now things are getting also easier with wearables. It's Apple Watch, Samsung Watch, Whoop, whatever brand it is. These things are for me very, very helpful. The more data I have, the better assessment we can do. So, and also one thing when I see on social media, do this for longevity, do this for health span. People do not really differentiate or are able to differentiate because they haven't learned what is health span, what is longevity. So longevity, you can be very healthy, but get, because you're predetermined or you're living close to a nuclear power plant, cancer. So to live longer, no matter what you eat, what you exercise, will be determined by catching the cancer in a very early stage. And for that, you need to go to the doctor and to a specialist and do special assessments to find that cancer early. If you see that, specifically Malaysia, but unfortunately also worldwide, very similar numbers, for male, prostate cancer is the second largest reason to die. The survival rate of a stage 1, stage 2 catched prostate cancer is 99%. That means that for these people who passed away, unfortunately,
They were in stage 3 and 4.
correct. And for prostate, this is, if you have colon cancer, it's very difficult to feel, or if you have pancreatic cancer. But with prostate, you usually have symptoms because the prostate is enlarged, so you have to go 2-3 times, correct. You have problems with urination. You had possibly within 3-4 years checkups where PSA should be absolutely mandatory for every male 40 plus. Possibly you had family history, so you should have gone and say, so I'm 40 plus. Let's do everything as possible: MRI, finger test, PSA, ultrasound, and then catch it in an early stage. And being literally healed, cured. It's not just extending the lifespan, but really curing the cancer. Very similar for breast cancer. If you have something in the breast, if you have the smallest, and females should do it monthly, just a self-check. There are fantastic videos online. The gynecologist will surely tell how to do it. Very easy. It's a 2-minute assessment. And
Monthly, you say? Wow, it's so aggressive. Huh?
it counts for the aggressiveness. But as soon as some little nod is turning up, you should go and check. And monthly, you have your menstruation monthly. So just to get into the track, you can do it 3 monthly, exactly, so that it's becoming a consistent habit. You can do it 3 monthly also. So it's not just because of the aggressiveness, but just that it's a habitual thing that you are checking your breast.
Okay, so back to the testing. I remember it was very specialized. You asked for several different things, and I think it was at a point when we had to go to 3 different centers to get it all tested. And I think the results took about 7 to 10 days for it to come out.
Unfortunately, yes.
Yeah, so the waiting time was full of anxiety. It's like usually you get these things and then 2 days or 1 day later. So specifically, what is the difference between your testing and a normal Malaysian general practitioner clinical test would ask for?
I wouldn't just say it's a Malaysian testing. It's a worldwide the same thing, because government and insurance restrictions are restricting the times that a doctor can spend with a patient. and also the money that they can spend. So I'm in a very luxurious and a good position that my patients are like you, more on the wealthier side, and can afford this testing. What is necessity? Again, so also time wise, you are willing to spend time with me. So it's not just that you come by, we draw the blood, and as I said, in 2 days we have the results, and I give you a call. So okay, you're fine. Come back next year. So that's not the sensibility. So I'm doing an overlapping health and longevity checkup, where again we are looking at your lifestyle. We are looking at possible risk factors that you have from the family. We are looking at optimizing your health. So not just you are okay at this time, there is nothing that is dangerous, but what can we improve so that you have a better well-being? So more concentration, more energy. Also, of course, at the same time, if you are talking about metabolism, for example, a lot of people are seeing, oh, I couldn't concentrate now, but I'm also in my 50s. So what the heck? It's age. Not realizing that they are having too much stress, they overeating, not exercising enough, and that causes metabolic syndromes in their body. So insulin resistance comes up. And with age also, you are producing less thyroid hormones, sexual hormones, which in younger age, if you ate 5 donuts, were not a problem. Now try to eat 5 donuts with 50.
I don't think I can finish one anymore. But yeah. Point.
So this is very important. Sleep is different because all our hormonal levels. So for me as an endocrinologist, of course, hormones are very important, and I'm quite fit in this area. So where I'm sending these tests away, and I'm sending you to other colleagues, are of course then heart, prostate, mental assessment if necessary, all these, so that we have a complete picture of everything ideally.
Okay, so how many things do you look for in the checkup?
Practically everything. So we are looking.
Well, it's not that many pages. I remember it's like 7 or 8, or maybe 10 pages. Yeah, probably 10 pages of results.
On a questionnaire or results?
The results, yeah. So it was quite detailed, but it wasn't your a lot of medical terms. So
again, on the blood test, these are just results. So 11 pages of results with over 150 markers. And you're right, they are not, by far not enough to have a real assessment, especially for longevity.
That's your first
step. That's the first pass. So we do, the blood is fantastic. I think you can read out a lot in the blood. But for example, the tumor markers in the blood are not 100% accurate.
I mean for cancer?
For cancer. So if we are looking for a cancer in the blood, there are certain markers like PSA, which are very specific and are quite good to 70% reliable in a positive and in a negative way, meaning that if it's above the normal range, then it doesn't say 100% that you have prostate cancer.
There's more investigation.
Exactly. Just go to the next level.
We just pull you back there.
Okay.
If there's a warning sign, then obviously it bears further investigation. But if it's all clear, can we trust that?
Again, that's where the family history comes in. So if you have family history of, for example, brother, father, grandfather had prostate cancer, and you still have, let's say, you 45, normal PSA levels, I still would go and send you to a urologist to have further examinations. If there's nothing in the family, I would wait until you're 50, 55, and then say, once a year, you still go to a urologist and have all the tests done additional to a PSA testing, which I cannot do. Yeah.
So that would be so you would still do the standard screen for cancer through the blood test. What else are you looking at?
Heart is also something where in the blood I can see certain signs for heart deficiency. ProBNP is a very, very early marker for that. But you need I cannot see how the vessels are clogged. So arteriosclerosis, which is practically a narrowing of the vessels, or an aneurysm, which is a widening, like a ballooning of a vessel, which can lead to a stroke, which can lead to a rupture in the blood vessel, that I cannot see in the blood.
So
So
what are you seeing from the test described?
on the blood test purely. So on the heart, relatively how strong your heart can still beat. So that is something that is visible on that, but not much more. So there we definitely need further testing, and that's why you saw a cardiologist.
Yeah, it's well, the reason why I pause over there is that the heart is obviously one of, isn't it that heart ailments are number one killer in the world? Is that the number one killer in the world, or is that's obviously more?
End of the day, yes, but we have to be very careful with statistics, because what should a doctor write in the death certificate? So you are
Morbid.
it's a little bit, but that's where the statistics are going into. So heart failure. Somebody is 98 years old.
You don't ask the second question. So why?
Correct. So what led to the heart failure? What led to that the heart stops, or multi-organ failure, etc.? So this is one of the reasons why, statistically, of course, when your heart stops to beat, you are dying. So
Heart failure.
then
It could be something else, right?
something that led to it, for example. Yeah. So, but heart attack, you're completely right. Heart attack is one of the major killers. It's still one of the major killers. Second is cancer. So a heart assessment is extremely important. And that has then again leading to it with metabolic syndromes. Because what builds up the hardening of the vessels, what leads to a narrowing of the vessels, what leads to stress, what leads to high blood pressure is multifactorial.
Lifestyle, diet.
Lifestyle, it's mostly lifestyle. Again, genetic predispositions also. But what the question is, of course, also later, so what can we do against it? Something that is genetically predisposed, we will not be able to change big time.
You can mitigate it. Exercise is
Correct. Absolutely, yeah.
and foods, I guess. Yeah.
Yeah, and more checkups. So again, coming more frequent, exactly, that's the right word. So more frequent checkup, we're doing more investigations, also medication, of course. So do you need medication? One of the medications where I'm surely prescribing much less than colleagues is statins, so for cholesterol, because there I see an overprescription.
What do statins do? Can I just?
That's a very interesting question, actually, because I think most people think that if I'm eating fat, the statins will somehow bind the fat and then release them through whatever way, but that's absolutely not the case. So most of the fats that we then measure in the blood are produced in the liver. So our liver produces cholesterol, and cholesterol is absolutely necessary because it makes up most of the sexual hormone basic structures. It makes up a lot of the carriers in our blood, where we're taking other important enzymes, etc. Piggyback and then transport it through the body to their destination. So it is nothing that is not absolutely necessary, but it can be then overloaded. And it's not the only culprit for heart disease. So when we go back to the 80s, 90s, it was practically cholesterol is the worst enemy for your heart.
Yeah, people still talk about cholesterol.
Oh, yes.
It always comes up, right? If you're eating fatty meat.
Correct. And it can be a problem, but it's not, first of all, the only problem. and it's not the uh, the only culprit causing the heart attack. So if we take into consideration other like inflammations are extremely important for heart disease. If we take other factors that are causing damage to the vessel, you must imagine that your arteries are not just a pipe like a copper pipe in your house, but they have different layers. So they have practically an inner skin. Then they have a muscle. This is what is controlling very often your blood pressure, because the artery can get wide or narrower. So that with the narrower, of course, your blood pressure goes up, which is very often necessary. And the widening brings your blood pressure down. So that's why this flexibility is very important. And with age, you lose a certain flexibility, elasticity of these.
Can I just ask then? Is it true? I know we're jumping a little bit. This will come back on that, but blueberries, it helps on the wall flexibility of your veins and arteries.
I'm sure that the blueberries, not blueberry. Well, I think that the amount should be very important, and certain components in the blueberries are helping with the elasticity in the artery walls. And there we are at a very important point, because blueberries contain not just that component, but contain also, of course, sugar, and so on and so on. So many components. So if we are able to identify the component which is directly supporting the elasticity of the artery walls, then ideally we are extracting it and giving it to you as a pure supplement. So, and they're becoming to supplements. So should we take supplements? Shouldn't we take supplements, etc.? Is it good to eat these? Absolutely. All the fruits, which in my opinion should be eaten and not drank. So anything you drink is bad, because it contains huge amounts of fructose, practically sugar, which is not good. Jumping back.
So if we jump back to statins.
Yeah. So the statins are inhibiting the liver to produce high amounts of cholesterol.
Oh, okay. I thought it was always related to the blood, but it deals with the liver.
It deals with the liver. But end of the day, the only place where we can measure properly the cholesterol levels are, of course, in the blood.
Right.
But the liver is producing it and releasing it into the bloodstream. And this is where we are trying then to lower the cholesterol, the total cholesterol level. So not the intake you can control from the outside, obviously. So exogenous intake.
Because actually the issue is not so much with your liver, but your liver is the one dealing with it. And whatever the byproduct the being dealt with at the liver affects the heart by way of the arteries and all the pipelines going into the heart, right? And that's the blood supply. That's I didn't know that. So statins would then deal with the liver in
production. So that inhibits the correct. It drives the
good and bad,
cholesterol. Right? The good and bad cholesterol is actually not cholesterol. The HDL, which stands for high density lipoprotein, or LDL, low density lipoprotein, is not the cholesterol. The cholesterol is always the same. It's like I'm driving out water. If I drive it out in a Mercedes or I drive it out in a Proton, that is the difference between the two. It's always the same water. So the HDL, let's say that's the Mercedes, the Proton is the LDL, the bad one. That is the carrier. And because the carrier is smaller, it can diffuse or enter into the wall of the artery better. And there are many very low density lipoproteins, etc. So we have now a much better understanding than 20 years ago. So also in the test, if you see the test, we had also LP little a, ApoA, ApoB, and the ratios. And these are very, very important also to see on long term how the total cholesterol and the low density cholesterol and the high density cholesterol are affecting you. And these all plays a role again, and your lifestyle plays a role if I would describe a statin. So I'm not describing a statin, and I think it shouldn't be described in the way, just because one marker is high. So you have to take all these markers, plus your questionnaire, plus your lifestyle, and possibly also what you are willing to do. Let's say somebody comes and didn't do exercise. He says, "So I'm very willing to change my lifestyle and do exercise, change possibly my diet." I would say, go ahead. We see us in 3 months. We check on these results, and then go from there. If it's still not low enough, we can consider statins, or there are even natural statins like red rice yeast, which end of the day also would have the same side effects, by the way. So just because it's natural doesn't mean it doesn't have any other unwanted effect on the body. Just like if you are drinking alcohol or wine, let's say wine. Wine is a good example because a lot of people claim to drink wine for health purposes.
That's just an excuse.
It's always an excuse. But nevertheless, a lot of people are doing it. So then you can say, so look, this is bad in that case. This is good in that case. How much you do it.
It's a set-off, right? It's a trade-off.
It's always a trade-off, and you have to have priorities and see that the patient also still has a certain quality of life, what they personally regard as quality of life, and not just go straight ahead. So for the statins, my personal highlight or an anecdote one, when I opened my first clinic, and the very petite 90-year-old lady came, thin, active. We did the blood test, and I was super high cholesterol level. So you have to take statins.
But she's 90.
She was 90, and again very fit, very, very fit. And she was laughing. But you learned in university and in your years. So high statin. So I was like, oh, you should take statin. She was laughing at me. So, young man, I have this since 50 years, and I'm not going to start now with any medication. And she was completely right, because the overall picture was she was already old. But even if she would have been 60, she was very active. Her diet regime was good. So she had a genetic predisposition for it. So she had from nature, because her liver is producing high amounts of fat. Even if she goes on a completely fat-free diet, she would have been on the upper end or even above what we consider normal levels. And that's maybe a discussion on its own, that the normal levels came down in the last 50 years. Of course, also because pharma companies want
to sell drugs.
They have to, and it's nothing against it, but you have to be careful and take many markers into consideration to really give patients then the medication. And I remember when I started out, it was 350 in European measures, and it's now to 220. I think that the high end is.
They brought the sensitivity levels down.
They brought the cutoff down, correct? Yeah. Of course, this is according to studies. So, it's better to have lower. It's better to have lower. It's better to have lower. No questions about it. But it's not just about the cholesterol levels, but again, inflammatory markers and inflammatory processes in your body are playing an extremely big role. If there's inflammation in your body, it will affect everything in your body in a negative way. So inflammation is one of the biggest enemies for the body. It's a little bit like if you take the example I said, the inner side of the artery is like a skin. If I go through a rose garden and have little cuts on my skin and then pour salt water over it, I will have pain, exactly. And if I do it often enough, the skin becomes harder, brittleish, not so elastic. inflamed, and with time, really, really, really bad. And the same thing happens on the inside. If you don't have the inflammation, it's much easier for the skin not to take up the cholesterol and then have it on the inside, and the wall becomes more narrow, it becomes less elastic. So you can have a higher level of cholesterol than somebody who has an inflammation.
So yeah, but there is no test for inflammation.
Oh, yes. The CRP, the HSCRP that we tested. Oh, that tells me.
In a person's body. Oh, really? I didn't. Oh, okay.
No.
Oh,
And
you
that's an
did- you did
unspecific test. Yeah, I mentioned that.
Yeah.
I'm pretty sure I
Yes, you
mentioned
did. You did. But I didn't focus on that because obviously it wasn't a problem. So
It
you
was-
don't
and it
focus
was
on what's
a
not a
lot.
problem.
It was definitely a
Yeah.
lot. And this is one of the most important tests, in my opinion, inflammation.
Because that actually can lead to so many other health issues,
Oh,
right? It's not just
Absolutely.
not just
Not just on the heart,
not
on
just
everything.
on the heart, everything,
Yeah.
right?
On all your organs, everywhere. Yeah. And it doesn't matter where the inflammation is. So with the test, I cannot say where the inflammation is. It can be a joint, it can be your gut, it can be your skin.
Would that also trigger white cells and so on? That's one.
Not necessarily. Not necessarily. There are, of course, links if it's a bacterial or viral infection, which where inflammation goes up, and you have then, of course, then an increase in leukocytes, specific in the neutrophils, etc. But if you have a joint inflammation, which comes from arthritis, or you banged your knee against the table, it can be inflamed.
And you would show up in the test.
That will show up in the test.
Okay, let me just come at you from a different direction. If you see there is inflammation, then you're not entirely sure where it's coming from. It bears further investigation, maybe more testing, but definitely a longer conversation with the patient.
Correct.
What if you see low inflammation? What if you don't see any inflammation at all? Then you would expect, let's say that's the first thing you read in a test as the
Super
doctor.
happy.
Then you just know that I don't have to worry about everything else, right? You're just super
At
happy.
that month,
At that point in time.
Yeah. Correct.
Okay.
Yeah.
So that's how important that inflammation
Oh, yeah.
test is. Would you say
That's
people test for
very,
that?
very-
That people do test for this all the time? Is that in regular?
The ESR, a very, very simple one, which is that can be done literally in every GP practice on site. And they usually do. Yeah.
But the one you tested for is
It's a more complicated one which has to be in a lab, but even that is usually tested. The problem is that it is not taken that seriously. And if it's elevated one time and there's no other symptom, so yeah, it's only 3 or 4. So if it's not sky high, then it's like, oh yeah, okay, that doesn't really matter. It should be then retested actually in 2-3 weeks to see if it stays there. If it was just because, again, you banged your knee or your elbow, or is it something that is continuous, chronic? And then we have the two ways. So we want to find out where it's coming from. If it's unclear, we still want to lower it. So you would get, for example, medication that lowers inflammation, which are anti-inflammatory drugs like aspirin, like ibuprofen.
would you say then that if you have an issue, whatever it is, inflammation normally accompanies that, or that you would see that? That I want to know how strong the correlation is.
Between any issue?
Well, what we said just now was that if you don't see anything on the inflammation marker on the test, then you're super happy. But let's now say you didn't test for that, okay, and you just saw somebody with heart ailment, cancer issue, or whatever. You would expect to see inflammation, wouldn't you?
Not necessarily.
But the correlation isn't direct.
It's not always there. It's not always there. But if you see somebody with a heart issue or a cancer, then at that point, the inflammation is your lesser worry. So if I see somebody with an inflammation in somebody supposedly healthy for a checkup, or who is coming with any other issue, then it might be an explanation why it came to the problems. But this is more important on health optimization and on the longevity, because again, a low grade inflammation, you won't feel anything. You don't feel bad, nothing. But it leads to just what we've discussed, that you, for example, your vessels are deteriorating at a much faster pace, and you are at risk much earlier for having a heart attack, having a stroke, and also for metabolic diseases. So no matter what you do, you change your lifestyle, but you still have the inflammation. You are not optimized. So what does the patient want? Again, we come to the very first question in the questionnaire. Well, if you remember, so what is your objective? What do you want out of what we are doing? So if you just say, so look, I'm expecting that in 10 days. I just want to be on the height. I would literally say, so
Enough time to write my will.
yeah, then we go, we do a different planning. Then if you say, so look, I want to play with 99 with my great grandchildren and be fit for it. so I'm adjusting to the patient's objective and not the other way around.
Right. Yeah. Well, I guess for you want to see your patients well, live well, and live long. Yeah.
Yeah. Star Trek.
The idea, but rarely do we all get what we want. So yeah. So okay, we've got those two covered. Those two are the big killers. But I think these days, a lot of people seem to have moved away from heart. Cancer obviously is still around a lot, fortunately. But these days, a lot of the focus is on diabetes, metabolic dysfunction, right, on that point. But really, it's really about diabetes. So you would obviously test for this.
Oh yeah.
That's a high priority test, I would say.
So again, if we come to what leads to the heart attack, heart disease, it's very often diabetes, because diabetes is damaging your vessels, damaging your nerves, damaging practically. We have now type 3 diabetes, which leads, according to newest studies, to Alzheimer's. So it's a very, very important problem, which unfortunately, again, worldwide is getting more prevalent. Reason is we become more wealthy, and with wealth we eat more. We eat more, we get lazy. I mean, that especially in Asia, Malaysia, nobody uses the feet anymore. Everything is done by a car. There is practically very little exercise done, and the prevalence is in the Middle East and in Malaysia for diabetes, and this is full diabetes, not just pre-diabetes, insulin resistance, which is already damaging. So an insulin resistance is something that I see as the biggest pandemic in the world at the moment. Because in every first and second world country, we are overeating. We are overeating with processed foods. We are overeating with sugars in any form. So it's not just, sweets, but it contains in all the supposedly healthy smoothies, etc. So people are not educated in what is really a healthy diet, what is dangerous in bigger amounts. So I'm also not a fan of a lot of social media influencers who are putting everything into toxic range. Fructose is toxic for you. So you eat an apple 2,000 years ago, apple was small and bitter, and now it's big and sweet. So obviously we developed apples to be more attractive and more tasty for us. But eating an apple is surely nothing that kills you. Unless you eat 50 apples a day, then it becomes too much. So we have to take into correlation what again was known thousands of years ago. The amount makes the toxin.
Right. The dose.
The dose makes the toxin.
Right. Well, on the blood, on the this is diabetes you would be testing on the blood, right? Not
Correct. Absolutely, yeah.
Yeah. So the thing here is, like we were talking just now about cancer, the fact that you catch prostate cancer early, stage 1, stage 2, you can fix it, can make it all go all the way, go away. And I think it's the same for diabetes now. For the longest time, people thought it was not reversible. But now, every time I walk past a bookshelf which has medical books on it, it's always about how diabetes is now reversible.
Okay.
Okay, with
Very true.
lifestyle changes,
Very
right?
true.
You know, it's almost like a trend. Everyone has.
It's a trend. It's an absolute trend. It's an absolute trend because you can use it also again for books, for supplements, for everything. But it's a good trend because it makes people realize, what do I eat? How can I change it? How can I bring down my sugar levels altogether? Or how can I metabolize? I think that is maybe the best expression. How can I metabolize what I eat in a more efficient way than before or earlier? And we have to differentiate very clearly between type 1 diabetes, which is where the pancreas is not able to produce insulin. And for these people, medication insulin is an absolute must.
They
And
die really quickly.
yeah,
That
correct. Yeah. And to shame them, which I see now more and more often in social media. So, oh, every diabetes can be cured. Oh, you just need to change your lifestyle and you're lazy if you don't do that. That's also not correct. For a type 2 diabetic, which is an industrial diabetes, because it's overeating, it's not exercising enough, not moving enough, that is for surely reversible. And for 99% of the affected people. So there we need compliance from the patient. And this is for a doctor a very difficult thing when they have only 5 to 10 minutes with the patient.
yes.
So explaining the patient what they have to do and then understand and getting them back into the office 2 weeks later, 3 weeks later, 2 months later, and see if they are complying with the recommendations, giving them the right recommendations, specifically in exercise, in food. Imagine you're the only one in your family and everybody else can eat the stuff, especially your kids, without any issues, current issues. And then everything has to be changed because of you. Exercise is in that portion, in my opinion, easier because that's you can do exercise alone. So that is a very complex socio-economic political issue, and where as a doctor I think you can focus on is your motivated patients. And again, I'm in a lucky position that I have patients who have more time, more money, maybe also more
Power, I think.
more willpower. Yeah, they're coming with a motivation. That most of my patients are not coming sick, just like yourself. They want to get optimized, and that helps me immensely. So my success rate is surely higher than a GP's, where he sees the patient who had already for 5-year diabetes, and he explained 10 times, you need to eat less, you need to exercise. It's not just medication. And the guy's like, yeah. Goes home, orders 3 pizzas, and sits in front of the TV. So there is nothing the doctor can do, and it's not the doctor's fault. And this is where I'm a little bit upset with the social media influencers, making them the apple, which has a higher sugar content than 2,000 years ago, bad, because this guy reads it and says, so, then it doesn't matter if I eat the apple or I eat my pizza. Both are bad. Yeah. So that's not true. So demonizing things is also not the right way. I think education is the right way, and that should start with kids in school.
Yeah.
Where we have nothing, where you have a health education. We have all kinds of educations in schools for we have, I think, 2 hours at my kids PE per week, and they play around with the ball. I think at least once a month they could take the time and explain also about food.
Well, and I think, a lot of it is also to do with school food, how frequent they eat. There's a lot of misunderstanding out there about, like you were saying just now, about don't drink your food. People think, they get their fruit juice and they're happy.
Yeah.
And then they take some cereal and what it says on the cereal box is no sugar, but actually sugar comes in so many
No
different
added
names.
sugar.
Yeah, no added sugar.
Yes, correct.
But who doesn't? I remember when I was a kid, I would add sugar to my cereal on top of the milk. So the diet, right, still remains
Yeah.
key. But could we actually, on the testing, I always, people always test for the glucose, right? So on your blood glucose levels, if you see that high, then obviously that's your main indicator for diabetes. Would you say?
Not necessarily. Again, it depends on how long you fasted. So if you're a 12-hour fast and your glucose is high, so this should be an absolute alarm sign.
So, which is quite normal. Most people will take their blood test first thing in the morning, the protocol, right? But the blood glucose, as I understand it from my own reading stuff, is it gives you an indication which could be false in the sense that your insulin levels could be very high, but they're not high enough yet. I don't know all the technical words, but the point is it's already moving. It's the blood glucose could be low because your insulin is high and it's already shifting everything to.
Correct. So this is the.
You help me out here.
The mark. So practically the definition, we have a wrong definition, or antiquated definition of diabetes. So diabetes has ABJ1C starts with 6.0 or 6.1, depending on the labs. And that is where then people say, oh, you're diabetic, so you are sick. But you are already far from optimal. A lot of my colleagues, including me, would say you are already sick if you are 5.7, which is now, and it's also only in the last few years, as a qualification as a pre-diabetic.
That is such a, excuse my language, that's such a bullshit term. You are either pregnant or not pregnant. You cannot be pre-pregnant.
So that's why the diabetes is, if you are above 6.1, you're diabetic, full stop. You're full diabetic. But that doesn't mean that with 5.7, you shouldn't optimize your dietary and exercise habits.
Yeah, that's the direction. You're heading that.
Correct. So that is where we need much more definitions and education, so that, look, you are super sick with 6.1. You're starting to be sick with 5.7. And ideally, you are 5.5 and below. And if you are super fit or, let's say, optimized in metabolic,
5.5 what? 5.7 what?
ABJ1C, sorry. So that and again on ABJ1C, this is a measurement which shows me how in the last 3 months your glucose metabolism was.
Okay.
So that, and even that can be on a normal side, again 5.7, 5.8, 5.9, which doesn't
say you don't have diabetes, because your insulin could be awry.
You are very much insulin resistant at these stages.
It's too late. No, it's still reversible, but obviously you've got a lot more work. But and I've had this conversation previously. Testing for blood glucose is one thing, but I did ask you then about testing for insulin. It's obviously your specialty, because I only found out recently insulin was actually a hormone. But to test for insulin in your, what would you call it, as an insulin test? That's apparently very sensitive because it's very volatile. It's not very stable.
The hormone insulin is not stable. So practically the moment where it's released into your bloodstream from the pancreas, from the beta cells, it is in 5 minutes then gone. 5 to 10 minutes. So if I measure some insulin in your blood, it just shows me the last 5 to 10 minutes.
Really? Okay.
And that means that can be too high because you just ate something, or it can be high because you ate 90 minutes ago something, or it can be high because you ate something 2 hours ago, so 120 minutes. and it depends on how fast it's falling down. Also the same with glucose. So how is the release? How is the uptake? So for this, if I do all my blood tests, we are checking for glucose, we are checking for ABJ1C. So these are then what is measuring the carbohydrates, and I'm measuring insulin and C-peptide, because C-peptide is produced together with insulin as a conjunctured molecule. And as soon as it's released into the bloodstream, they part ways. Insulin is doing its job, and C-peptide is much more stable. So there I have much more time to measure the complete output from your beta cells. So that's why C-peptide for me is very, very important to see, are you really producing too much insulin over time?
It's not a standard test.
That's not a standard test. That's a test which is actually rather rare, and usually are only done if we are already diabetic type 2, and maybe there's an insulinoma. So not a standard test, unfortunately, at all. If you want to go into a super optimization, you would come to the office for an oral glucose tolerance test. So that is something where I can really see how fast you are metabolizing glucose, how your insulin is peaking, and then how the cells are taking up as response to the insulin, the glucose. So this test is done that in a way that you are coming to the office in the morning, again 8 to 12 hours fasted. Then you are receiving a quite nasty tasting liquid which contains 75. That's the standard value. 75 grams of sugar.
You just give people a Coke or a Pepsi. That's plenty of sugar in there too. Tastes better.
Absolutely. Very true, but we have to standardize
Yes,
again
I'm sure.
the amount completely, and we have to standardize to the response that we are getting. And Pepsi doesn't have that. So you drink that, and then we start to measure 30 minutes later the glucose and the insulin in the blood. Then 60 minutes later, 90 minutes later, 120 minutes later. And then according to how the curves are adjusting, we can tell if you are insulin resistant, optimal, or can be further optimized.
Would that be called metabolic flexibility? That's the term.
Can be
That's the
can be
term for
called,
it, right? That's how you use
yeah,
the energy.
correct, yeah. How you uptake it, how you use it up, how your body is reacting to it. So this would be a very good expression for it, metabolic flexibility. This is a quite new term. There are many new terms coming up which are much better describing things than we do in medicine in med school, to be honest.
Well, I was listening to someone else say this, and I think, well, I guess this would be true. There's always going to be a visual clue as to how healthy a person is, especially with diabetes.
You mean from the outside, or visualizing the patient per se?
Yes, because I was told, or rather I read this, that if you're a male, doesn't even talk about height. If you're a male with a 40-inch waist, it's very likely that you have metabolic dysfunction. And if you're a female, I think it goes to 35 inches. So this was American podcast which I was just listening to. So I guess the average height there would be even taller than Asians. But the point I'm trying to say is that if you are fat, then it's much more likely that you are going to have metabolic dysfunction leading possibly to diabetes as one of.
Much more likely, absolutely, of course. I mean, that, and there it doesn't matter if it's 40, 45, or 35. It's really depending on height, ratio, etc. And I'm not a fan of these one marker ratios.
Well, the other ratio I heard, and this is interesting, Gabriel, was that if you take your waist and you multiply it by 2, and if you are if it's more than your height in inches or cm, whichever you want to do, but just make sure they match up, then that's the same thing. I mean, this is for people who don't want to go through testing, but it's just one way to know your insulin issues and so on.
If you take your waist measure, you multiply by 2 and it's higher than your height, I'm pretty sure you have problems. I mean, they're
Quite clear, right?
quite clear. So there you don't need this measurement at all. So it's something like the BMI. BMI is so popular, but the BMI is also absolutely misleading. You can take it maybe for 60, 70% for population, but it has no diagnostic value at all.
Yeah, it's a waste of time.
It's a complete, and it can be absolutely misleading. So if you again just see the number and you don't see the patient, it's very similar to the questionnaire and blood test. You see a BMI of 30 and you're like, Jesus Christ, this guy must be horribly and out of shape, almost dying. And then you see a bodybuilder, a very, very fit guy. You're like, yeah. But it makes sense because fat is very light, muscles are heavy. So somebody with 180, like 6 foot, zero fat on his body, but weighing 100 kilos pure muscle, has a BMI, which according to the scale is completely obese. Guy stops working out, eats even less than he used to. Within 3 months, he loses muscle, he builds up fat, and is most likely starting to be sick metabolically. But his BMI improved. So that's why I'm completely against these one number and measure and square it and then we know exactly what's happening.
Okay, so in your testing, you're looking at cancer, heart, diabetes, inflammation. I think we've covered that.
All the hormones, obviously, for all the hormones. I mean, this is some, yeah.
I remember that, and that's not just because you're an endocrinologist, but I think that's actually very, very important, right? For everything. I mean, it seems to dictate all our lives.
Yes, definitely. I mean, everything dictates our lives. So again, but hormones are very, very powerful. So if we are going into weight loss, for example, and everybody, do a little bit of this, eat less. If I just add a little bit of thyroid hormones, you will lose super fast weight. So if you see boxers, they have to have a very, very leveled weight. So a heavy weight wants to go in. He doesn't want to be 5 kilos below the allowed. He wants to meet that weight exactly because that means also muscles.
Right. He's at his optimum weight, fighting weight.
Correct. And
the best way to do that is to
live healthy and meet the weight. That's the best way. But I mean, this is professional sports. And although it's not healthy and not allowed, it's very often used. And their thyroxine T3 is used mostly a week before a fight it's called make weight. So get it fast down. It has also sometimes the aspect that people become more aggressive. They are pumped up. They are literally getting tensed, yeah, and they can lose very fast these 1.5, 2 kilos that they need to make on that. And on the last hours, that you can also see in all the documentaries, they're going into the sauna, so getting everything on fluid out of their bodies.
They should test them just before they fight. Just like 20 minutes before you ring the bell.
Again, if you lose fluid, that can be tested. You're dehydrated, but it's not something that goes against the doping.
So all right. So in your testing, you would test for thyroid,
sexual hormones, steroids, obviously also for the metabolic ones like insulin. So everything is tested. Also the antibodies are tested. Also one of the reasons also we are testing for iodine, for magnesium, for zinc, for iron, is because they play a role in the hormonal overall health.
So your wellness would be dictated a lot. How you feel
very much,
is really very much hormone.
Yeah.
Hormone.
Correct. So we just made a podcast lately about the thyroid, and worldwide there are 750 million people with a thyroid problem.
Really? That's like 10% of the
10% of the world population. And now make a wild guess how many of them don't know about their condition.
all of them.
Not that bad, but 450 million, 60% are not aware that the thyroid is not functioning properly.
What are the symptoms of thyroid dysfunction?
That's the problem. The symptoms are
What the testing
so
should show,
wide,
right? Yeah.
so wide, so diverse, from just feeling a little bit down, not being able to perform in the way that you used to, sleep problems, little bit of weight gain, weight loss. You cannot lose the weight that oh, I'm dieting, I'm exercising.
So it's also your mood, how you feel.
Mood is very much affected, up to depression, up to full-fledged depression. And again, I can't talk about it because I don't have a thyroid anymore. So I had Graves' disease, or have Graves' disease, and my thyroid was taken out 30 years ago. So I'm taking every day the hormones. And I'm sometimes playing around just for this reason to, I put on weight and want to lose it faster. So I increase my T3 a little bit. The problem there is I'm reacting much faster psychologically to the T3 than metabolically. And I'm becoming very agitated. I'm getting panic attacks before I lose the weight. so I'm trying to get it 2 days, okay, and then leave the medication away, play around. But my advantage is that I have 30 years of experience and also knowledge with it. So I definitely wouldn't recommend it to anybody at home. But it's a very, very sensitive area. And again, we know the list of what is happening with mostly hypothyroidism, but it comes out in everybody a little bit different. And this is what the questionnaire is important. What are your symptoms? What if your wellness is okay and we detect something that is slightly off, do we want to change that? You're feeling very well, your body is in a good shape. Why should I change it? So making just blood cosmetics, this is what I'm usually calling it, and this is why I usually refuse to say, so you're sending me your blood test and, oh, this is what you need to take, without me knowing your condition. It's just making or trying to make this blood test better, but not helping you with your well-being. Yeah. So that's not a sensible thing.
Right? One needs to investigate first.
It's a completely wrong way to, again, it's like having the house on the outside shiny and on the inside it's rotten and falling apart. So that's not the right way to sell or renovate the house. And this is also why we need more data. So normally, very specifically for the thyroid, TSH is measured, which is produced in the brain, and said, so if TSH is okay, then your thyroid works. It works, but you're not optimized. So you can be still being off your optimal levels, but you're not sick in the sense as we understand from a universitary book-like point of view, where we're defining if this guy is really, really sick, then his TSH is off, his thyroid is too small, too large. That's sickness, but not optimal health.
It's more like if you're feeling lousy, this is one of the reasons.
Oh yeah, very often.
Always
very,
a
very often.
hormonal imbalance. Something
that's the perfect word for it. It's a hormonal imbalance. It's not a hormonal sickness. It's a hormonal imbalance. Very much like ladies, if they start to go into menopause, so practically perimenopause, where and this is a very good example because that happens very fast. So all our hormone glands with age deteriorate. This is what happens just with a car. It's getting old. It's you pump out less,
But doesn't mean you're
less
imbalanced.
production.
It just means you're
Not optimal. Yeah, but again, we don't want to get old and not function on our highest level. And nowadays we can, because we can improve the output either by exogenous sources like pills, creams, whatever, or by improving the real output inside your body with stem cells. So that is what actually stem cells do in that body then, that they are really giving that gland a new shine, a new.
stem cells help a lot with hormonal imbalance.
This is actually the one of the best things for stem cells, because that is a natural way to improve the function. So if we are injecting stem cell, the balance is then controlled by your body. This is why it's natural. If I give exogenous, so what I'm doing is I don't have the thyroid anymore. I have to take medication, which is a prefixed amount. So I cannot adjust from the outside, not as fast as my body can adjust from the inside.
Which is why you're saying that it's better with the stem cells, because it's
Correct. So they practically imagine a factory where you have old machines. They are not properly maintained. So the stem cells come in, it's a maintenance crew. It's putting up the machines again to a level where your capacity or you refurbish and your output increases. And again, you need your workers who are adjusting how much you really put out and how much goes into the warehouse, how much is sold. But the production is guaranteed. So that's if you take the other example. Otherwise, you have the workers, you have the warehouse, but your production, you cannot drive up, not naturally. And these guys are like, hey, I need more, I need less, da da da. All these playing a role. This is why it's the most natural way.
because all of it goes hand in hand. You could, so stem cells would just balance it out. Your body it would help your body balance it out. That's
Correct. That's the way.
okay. So hormones is one. I noticed in my report, vitamin D you tested for as well.
Yeah. Again, vitamin D is mistakenly.
And it's not common. I don't see that common.
No, unfortunately not. It's getting more and more popular because during COVID we saw that people with a higher level of vitamin D didn't land. So they got COVID. So don't misunderstand me. It's not like, oh, it protected against COVID.
They just recovered or faster.
They didn't
Milder symptoms.
The symptoms were milder, so they didn't land that often in the ICUs. So even if they had symptoms, the whole course of COVID was less dangerous.
Yeah, that's these days.
And it's a hormone.
It's a hormone.
Vitamin D is mislabeled as a vitamin. It's actually a hormone because it's produced by the body. So everything where you can say, so this is produced by my body is a hormone. So vitamin D is a hormone, reacts also as a hormone. But we bring vitamin D always bones vitamin D. That's the only thing I think that people usually know about vitamin D. Oh, I need it for my bone health. But vitamin D you need for your immune system. You need it for as a cofactor. It is practically produced through light on the skin. So ideally. And in 90% of people I'm measuring it, it's too low.
In my case too, yes.
Yes. So you were in a normal range.
I was a borderline actually. So
so you were quite good. Yeah, you were actually quite a bit borderline. You're already good. Yeah, it's a real deficiency. It's a real deficiency that we see.
So if you're in a country which doesn't get much sunlight, or you yourself don't go out in the sun much, then you're always going to be at risk. But it's interesting, even if you are living in sunny tropical country, you can still have vitamin D deficiency.
You can. I mean, this is also a racial issue. Obviously, if you have darker skin, then you need more sunlight to produce again the vitamin D. And there are certainly also genetic factors where I don't know any study about it, where different levels have different effects. So there's definitely much, much more to learn. But what we can see is that higher levels, not toxic levels, but higher levels, and because it's a fat soluble molecule, it can be also overdosed. So it should be regularly tested so that people who are supplementing are not overdosing it. So we have to again meet the nice middle ground on that. But because this is a necessity for all other bodily functions, same with iron. Iron is a very good example because that is really tested very often because it's clear iron I need to build up red blood cells, especially in ladies who have regular menstruation. It's very easy then to see, so, okay, oh, you have heavy menstrual bleedings. Your iron is missing, ferritin is missing. You need to supplement it to not being constantly tired. But again, we have to check first, and the first check is red blood cells or looking for a sickness. So are you coming with something, I'm feeling horrible, so I'm throwing up since 2 weeks. I cannot sleep. My eyes are yellowish. There we need a completely different checkup, and then somebody coming. So, the last 2 years I put on weight. I don't feel as energetic as I was before. Let's see if we can change that. So the conversation with the patient is mandatory, absolutely mandatory.
So, okay, what else would you say is the way you test? What you test for is different from what others do. I think we've mentioned quite a bit now. What else?
Again, the extensiveness of the testing, and it's not just me. I mean, there are many colleagues also doing in that.
Have a different protocol, but we trust you. My family trusts you. So, what else would you test for outside of the norm?
Again, I would rather recommend also colleagues who are specialists for ladies, for male, again, for cardio, for if I see that the stress is very high, seeing also a mental health specialist, but also more and more into genetic testing. So I'm not. It's very popular now, especially here in Asia, to buy genetic testings, Facebook, but it's very difficult to interpret it. So it's very, very confusing what the results are, what you have to do with the results, and generic results. What I see, people are coming with, oh, I did this test now, and it says I'm getting breast cancer. Yeah, especially on the cancer side, it's very, very sensitive, I think, and there the laws in Germany especially are much stricter. So if you have genetic testing, you have to do it with a specialist. You have to have at least, before the testing, you have to have at least 2 hours of conversation with the specialist, where your also your mindset is evaluated.
Well, isn't that the test itself isn't onerous? It's just basically a swab for your mouth.
Oh yeah,
you know?
yeah. Very easy.
What you mean is that you just don't want people to get carried away by looking at it and saying like, oh my God, you might have a predisposition to whatever, this cancer, or that
Very
cancer.
dangerous.
Actually, that's not quite true, right?
Correct.
Yeah. Because one has to go deeper, and so it's a
much deeper, and it can't say if you get cancer or don't get cancer. What it does is, again, a statistics. It says you are more likely to get cancer than the median amount of people, or less likely. Both can get cancer, but again, if I see it's a high likeliness, the only thing I would recommend is do more frequent checkups.
it's almost like you're looking for signs, and I mean, if you're that sort of a person, then you work towards. It's given you a sign that you could possibly get it. You're not. Doesn't mean you're guaranteed to get it, but it's an indication that you might be susceptible to this. So you might want to, as you said, more frequent testing, and maybe changes in lifestyle would be warranted.
Correct. Absolutely. So do I do smoking, and I have a higher genetic risk anyway for lung cancer? I would say the thing that you can definitely change is tomorrow to stop smoking. And if you don't want it again, then do even more frequent uh, checkups. So it's always a conversation with the patient, always an individualized therapeutic start. But the testing is always the base for any therapeutic measure. Without a testing, it's not necessary to even think about therapies, because it's a guess. It's gambling.
Well, I would actually go so far as to say that, if you just test, and obviously if you don't test for the right thing, you're never going to get the result you want, or never going to get a right result, right? So you were saying that, yeah, there's quite a bit of work to do before you actually undergo the test, because I need to talk a little bit more. I need to understand the context,
Correct.
the results, right? So if somebody were to tell you, yeah, you just get a blood test and tomorrow I give you the results and okay, it's all clear, that doesn't mean you're all clear.
Correct.
So what we're saying here is that the right way to go about this is, yeah, you still draw the same amount of blood, you still give the same amount of urine, but now we have to, before I can even decide what to test you for, aside from what we've just discussed in the last hour, is that we need to have a conversation about family history, how you feel, what your lifestyle is about, what you like to eat, what you don't like to eat, and so on and so on.
Right. And what are your goals?
And yes, and finally, what are your
What are your
goals?
goals? What do you want to achieve? If somebody is a squash player, says, so I want to play with 80 squash, that's going to be very difficult, because the older you get, the higher the risk of injuries. So if we want to say, so health span, lifespan, we want to diminish injuries. So, and that plays in a role. So what you do, you are horseback riding, big injury risk. So better you stop it. So this is something that I see as my responsibility, and it's a coaching. It's an absolute coaching. So I give you these options. So this is optimal, and then you tell me, so what, I love horseback riding. So no way that I stop that.
Well, I think in my case, when you looked at my report, I think you said that I should cut back on carbo, but I was not diabetic. I was not even pre-diabetic.
No.
But I like pasta.
Insulin
I like
resistant.
rice. Yeah, but I'm not insulin resistant.
At that point, you were.
Was I?
As far as I remember, yes.
Yeah, I think
that was the reason. Yeah.
I think you asked me to increase my, well, either build muscle, because muscle would use up a lot more of the carbo, or increase my exercise duration doing type 2 intensity. But I guess that can be for another podcast. So I've been doing that. And
it's amazing. I mean, I'm
a lot of weight.
envying you. Yeah, I'm envying you.
These days, instead of just swimming half an hour, I'm doing 45, 50 minutes, and it's so boring.
Really, I find swimming, I can relax and have my thoughts concentrated.
Okay.
Yeah. So I can focus while I swim. The worst thing in swimming is that I cannot write up my thoughts. I have to remember that later. And then later, of course, it's like,
you have to have a notepad next to the pool.
or screaming it out. So, yeah.
But yeah, that's all good. That actually came from doing the test. Lifestyle changes. Changes on my diet too as well. I'm cutting down my carbo. Instead of my usual 3 bowls of rice, I'm doing 1.5.
That's huge difference. Yeah.
Yeah, that might be an exaggeration. But yeah, I am cutting whatever.
Yeah. And you did fasting.
Yes, I've been doing a lot of fasting. I've been doing a lot more fasting, actually. But again, we should talk a little bit more about
yeah,
this.
Definitely. I would love to come back and do fasting with an expert, because on fasting I know the basics, but I have some friends who are real experts in that. So maybe, yeah, correct. They are leading. Yeah, very interesting. They are leading the Buchinger Clinic, for example, on the scientific side. So we can. we invite them on the screen. So we sit down, the three of us, and then getting questions from myself, questions from yourself, and he's an extremely nice and very, very knowledgeable guy in this direction. And there are pros and cons, of course, for doing fasting.
I think we're concluding.
Yeah, yeah.
You would recommend fasting, right? In as short as possible.
Let's say intermittent fasting, definitely. Longer fastings for specific people with specific conditions, yes. Always with a medical oversight. So not oh yeah, I want to lose weight, so I'm fasting now for a week. Is in my opinion a very bad approach. So this fasting, seeing just in correlation with weight loss instead of healthier, improving well-being, which is a much better way altogether. Yeah, very complex. Thank you so much for coming, and I'm looking forward for the next one. Yeah.
Legal disclaimer. This podcast and website reflect the opinions of Dr. Gabriel Peter Salgo and his guests. The content provided here is not intended as medical advice and is solely for informational purposes. Given the unique nature of individuals, it is advisable to consult a healthcare professional for any medical concerns. The views expressed herein are our own and do not necessarily reflect those of our respective workplaces. While we strive for accuracy in the information shared, we welcome feedback and corrections. Privacy is paramount to us, and any references to individuals, locations, or scenarios have been altered to safeguard patient confidentiality. This podcast and website should not be construed in a legal capacity, including establishing a standard of care or as the basis for expert witness testimony. We do not guarantee the accuracy of statements or opinions expressed herein. Engagement with our content, whether through listening, reading, emailing, or social media interaction, does not establish a doctor-patient relationship. Should any errors be identified in our content, please contact us through the provided channels. Ownership of this podcast belongs to Pura Vida Healthline SDN BHD. Our content may include affiliate links, through which we earn a commission on sales made through those links. As a participant in the Amazon affiliate program, we may earn from qualifying purchases made through our links. Disclosures. Dr. Gabriel Peter Salgo is the co-founder of Pura Vida Healthline SDN BHD. Dr. Gabriel Peter Salgo is a scientific advisor, board member, and/or investor to Molagen H, Jada Kind Ltd, Ixon Research, and receives compensation from these companies.